What's up, everybody? Welcome back to Pain Points, where Dr. Miles Nicholas and I are talking about the hottest trends in fitness and rehab. Today, we're going to talk about using tolerance as a guide for prescribing exercise intensity in people that have pain versus exertion. But before we start talking about training to tolerance, let's talk about using RPE, or rating of perceived exertion. RPE is used traditionally in the performance realm by personal trainers and strength coaches to help increase performance-based goals, but we like to use it also to guide loading decisions in the rehab process as well. And if we go by the concept that you mentioned in a prior video of starting low and going slow, a good general guideline is that you can reintegrate exercise at the RPE 3 to 4 out of 10 range. So this is something we teach in our online courses. If you go through it, this is something we teach in our live courses. But recently I've been thinking, and we've had a couple questions come up at live courses of, well, how do you really know what an RPE 3 to 4 is? Can we accurately rate it? And how do we account for people that have low tolerability to a movement at low exertional levels? So they start to have pain and symptoms far beneath their exertional threshold. In my opinion, the RPE scale doesn't work as well in this situation. So instead of prescribing it based on RPE, we can help guide loading decisions based on the client's tolerance. So that really brings up the concept of rating of perceived tolerance, or prescribing exercise based on tolerance. So with that, how would you use tolerance as a guideline for prescribing exercise based on instead of overall exertion?
Yeah, so I think the reason that we even do this in the first place is because when someone's in pain, they're likely not going to hit that exertional threshold anyway.
You can't.
Certain instances, maybe someone can just, it's the right presentation, someone can grind it out, but so often you're not going to be able to create the same amount of muscle force production anyway. So to answer your question, tolerance is a great place to start, because it's less, if RPE is how many more reps could you have done on a given lift in a given moment, the rating of perceived tolerance is how many more do you feel like you should have done? Or how many more could you do tolerably? And it's a situation where my RPE 7, 3 reps in reserve on a lift when I feel great, versus my RPE 7 when I'm dealing with pain, that's going to be lower in the first place. So furthermore, we kind of lose the validity of the RPE scale in the first place. So it's kind of like, why don't we instead say, let's find a weight where you can do a certain number of reps at an RPT, rating of perceived tolerance of 7, meaning you feel like you could have done 3 more reps that would have been tolerable, versus 3 more reps that you could have done exertionally.
Exactly. So for those of you who haven't seen, I just wrote a brand new article on this concept, rating of perceived tolerance. And of course, there's probably other clinicians and coaches out there, well, there should be, right? Prescribing exercise based on tolerance. But to my knowledge, and I don't want to step on anyone's toes, we have yet to actually conceptualize this in a scale. And if you read that article, and we'll talk a little bit about it now, but basically what we recommend here is, let's take an RPE 10 out of 10. And we basically say that an RPE 10 out of 10 is, if you rate a set a 10 out of 10, that is the most amount of reps you could have done from a pure exertional standpoint. Meaning that if you tried your darndest to do another rep, it's not going to happen.
It's not going.
It's based on exertion. If we reframe on the RPT scale, if we reframe that 10 out of 10 as a 10 out of 10 being the last tolerable rep a client could do, meaning from an exertional standpoint, you probably could do more, but it's going to exceed the tolerance threshold. So that goes back to what you said of, you could have done another rep, but we probably should not have done. So we can reframe that 10 out of 10 as the tolerance threshold. And I hypothesize that this could be very useful in the clinic. So if instead of prescribing exercise and starting out at an RPE 3 to 4, and we already know that it can be very difficult to accurately rate RPE on submaximal
if you're far away from
far away from 10 out of 10. We know this. instead of reintegrating a lift at 3 out of 10 RPE, maybe we reintegrate it at 7 or 8 out of 10 RPT, meaning on day 1, we can work up to a weight that is just a few reps shy of the client's tolerance threshold versus being God knows how many reps shy of their exertional threshold.
Yeah, that makes complete sense.
So that's where we really come from a rating of perceived tolerance scale.
And what I would even add there is kind of almost going back, but putting it in a more succinct fashion, especially for the physical therapists, chiros, the rehab providers out there. If you're using RPE in clinic, in most situations, you're using RPT anyway.
Exactly.
So what we're really doing is we're just, putting it out there as a concept that let's make it a real thing that we're going to acknowledge that we're not truly working at an RPE anyway.
Yeah.
We're working at their tolerance level. And so I do think that where it helps is that now we're framing it to the patients in that fashion. How many more could you do tolerably, as opposed to, I want you to push until you could have done 3 more reps. Because then the patient, the client, doesn't exactly know, like, 3 more reps total, like if I push through whatever I can, or 3 more reps that I feel good about for today.
Yep, and that's what really matters. And just like RPE, there's going to be autoregulation here when tolerance levels are going to fluctuate on a day-to-day basis based on recovery, based on all kind of different factors. So this works from an autoregulation standpoint as well, using this tolerance guideline. So let me give you a prime example of when this situation would really work out well. So 2 years ago, I was dealing with shoulder pain during the dumbbell bench at low loads. So my plan was to work up to 80-pound dumbbells for 3 to 4 sets of 8. But training started becoming intolerable. Intolerable? Intolerable?
Yeah, intolerable.
We'll go with intolerable. Training started becoming intolerable around the 55s. So I had a decision to make that day. I was frustrated and I was like, now I know I could work up to the 80s if I really, really wanted to, but my shoulder's going to be screaming if I do. And right around the 55s is right when I was on that tolerance threshold. And if we're using the concept of RPE, the 55s were right around that 9, 10. If I kept going up in weight, I would have exceeded my tolerance threshold, but I still would have, the 55s were like an RPE 4 for me.
Exactly.
So this was a perfect example of, I needed a different way to frame what a 10 out of 10 was in order to help guide my loading decisions for that day. So what we did, and if you've attended any of our courses, we have a heuristic model of, that was the case of, I just needed to take 3 to 4 weeks to rebuild my tolerance threshold up by working either right at it or slightly below it. So I was essentially working in the 8 to 9 out of 10 RPT range for about 4 to 5 weeks, where guess what? The week after, I was able to do 60s at an RPT 9. The week after that, I was able to do 65, 70s at an RPT 8, 9. Now, don't get confused and assume that this process is linear. It's not always going to be linear. Your RPT can change, or what your 10 out of 10 can change on a week-to-week basis, but we should see an improvement over weeks and months, right? Always looks sort of like the stock market, or at least it looks like what we hope the stock market should look like. We hope it doesn't. Well, you guys are I'm facing the camera this way. Anyways, you get what I'm saying. It was a perfect example of how I slowly was able to raise my tolerance threshold until I no longer had pain, and essentially the RPT 10 equaled an RPE 10. So training based on tolerance is really good for the rehab process, because it's going to consistently change until that pain gradually dissipates and your exertional threshold will either equal or be pretty darn close to what your tolerance threshold is. Anything to add to that?
No, I honestly think that ties it up really well.
Yeah, so if you guys want to learn more about RPT, I'll put the link in the description here if you're watching on YouTube. If you're watching on Instagram, just head to our website and go to our blog, learn more about rating of perceived tolerance. Great tool for clinicians to use in the clinic to help guide loading decisions during the rehab process. So if you're still here, thanks for watching this, and come back next time for Pain Points.